Bismillahir Rahmanir Rahim. Our lecture today is about obstructive sleep apnea syndrome, which is very important subject, and really it is underestimated whether by the ENTist or by physicians. Patients who are complaining from the symptoms always or sometimes attributed to other causes rather than the obstructive sleep apnea syndrome. What's apnea? Apnea is defined as the cessation of air flow at the nostrils and mouth for 10 or more seconds. Obstructive sleep apnea is defined by the absence of airflow despite persistent ventilatory effort demonstrated by contraction of the respiratory muscles such as the diaphragm, while OSAS refers to findings of obstructive sleep apnea in combination with symptoms related to sleep deprivation like daytime somnolence and fatigue, morning headache, and depression, or cardiopulmonary dysfunction like systemic hypertension, coronary artery diseases, arrhythmia, cerebrovascular accidents, pulmonary hypertension, cor-pulmonal, and polycythemia. The prevalence rate of OSAS is around 4 to 2% in males and females respectively. OSA involves a physical obstruction in the upper airways, mainly in the oropharyngeal area. The condition tends to affect mainly obese people. If it is uncorrected, the disorder often leads to central sleep apnea, hypertension, cardiac abnormalities, and pulmonary failure. Polysomnography is considered the gold standard in the diagnosis of obstructive sleep apnea. Really in our community في مجتمعاتنا غالبا اللي يعاني يشخر أو عنده أعراض يعزوها إلى أنه المشكلة في الأنف، ولكن غالبا the problem in the oropharynx. البوليسومنوغرافي as I said is the gold standard، وحقيقة أنه بالعراق ما موجودة، أعتقد أنه موجودة فقط في مدينة الناصرية. أنا برأيي أنه اقترح في كل مركز محافظة المفروض هناك polysomnograph. The risk factors for obstructive sleep apnea. They include obesity, male gender, 2 to 1, male to female, anatomic abnormalities that narrow the upper airways, such as nasal obstruction, adenotonsillar hypertrophy, macroglossia, family history of sleep apnea, smoking, sedatives, and alcohol, and other factors. You can see this picture, even he looks, the patient not too obese. Non-obese patients can develop also obstructive sleep apnea syndrome. See the common physical findings: enlarged tongue, overweight, obesity, enlarged tonsils and or uvula, small lower jaw or retruded chin, nasal polyps, congestion, sinusitis, and other findings. while the common signs and symptoms like snoring, irritability, personality change, depression, excessive daytime sleepiness, poor memory and confusion, nighttime sweating, and many other symptoms. Really, many accidents in the ways, car accidents, mostly due to sleep during driving because of obstructive sleep apnea. How we diagnose? Diagnosis, first of all, clinical evaluation depends on history, physical examination, and imaging. 2. Polysomnography, as we said, it is the gold standard in the management, or in the diagnosis. The following characteristics are diagnostic: 30 episodes of apnea within 7 hours. 1% of patients' sleeping time is spent in apnea. C. 10 times of apnea in 1 hour. حقيقة هو بالنسبة للبوليسومنوغراف عبارة عن غرفة نوم ينام بها المريض ويشيك الاي سي جي، البلس ريت، الاكسجين، attacks of apnea. All these are recorded and then evaluated. Treatment. How we treat a patient with obstructive sleep apnea syndrome? First of all, behavioral interventions like weight loss in all obese patients. Alcohol and sedatives should be avoided, and avoidance of supine position. 2. Medical intervention. A. Pharmacological treatment and has a limited role like nasal decongestants, intranasal steroids, and antihistamines to relieve nasal blockage. B. Oxygen supplementation. C. Oral dental appliance. D. Continuous positive airway pressure. The term we say CPAP, CPAP, continuous positive airway pressure. This method, if tolerated by the patient, represents the most effective treatment, and success rate of CPAP approach 85%. CPAP therapy is almost never used for non-apneic snoring because it is disturbing. See this CPAP. It is disturbing for the patient. Very disturbing. واحد وهو نايم شاد له جهاز ومركبه بهالصيغه، فطبعا يكون جدا مزعج. لكن المريض انه في حالات انه شديده لا ما اذا عنده ابنيا وغيرها يضطر انه يستخدم. Now we go to third method of treatment, which is the surgical intervention. Many surgical procedures are available for the treatment of OSAS. First, nasal surgery like septoplasty, inferior terminectomy, and polybectomy. B. Laser-assisted uvulopalatoplasty (LAU) can be used effectively in treatment of snoring and OSAS. C. Radiofrequency volume reduction of soft palate, somnoplasty. We make the soft palate smaller because this acts as a valve to do obstruction in the oropharynx. It uses low temperature energy to produce submucosal coagulation necrosis and later scar formation, which results in volume contraction and soft tissue stiffening. D. Tonsillectomy. The most common cause of pediatric obstructive sleep apnea is obstructive hypertrophoid adenotonsillar hyperplasia, and so tonsillectomy with or without adenoidectomy is effective for its cure. E. Uvulopalatopharyngoplasty, U-P. We call it U-P from the term uvula palate, pharynx, one of the way to remove the tonsils if present, is the most common operation performed for osseous, and this designed to relieve oropharyngeal obstruction through excision of redundant soft palate tissues that involves the free margin of the soft palate, uvula and posterolateral pharyngeal wall. If the tonsils are present, it will be removed first, while palatal surgery is the most commonly performed surgery for non-apneic snoring in adults. The use of UPPP for children with osseous has been restricted to children with osseous and craniofacial or neuromotor problems. When compared with adults, children with obstructive apnea are more likely to have partial apneas with hypoventilation. حقيقة أنا مريض واحد فقط اللي إنه بالأطفال سويت له UTRIP اللي هو كان عنده craniofacial abnormalities. The last surgical procedure is procedures like lingual tonsillectomy, midline glossectomy, and mandibular advancement. Really, this advanced surgery and will be done in severe cases. Now we go to another subject, which is nasopharyngeal angiofibroma. There are many benign tumors, but the most important here is the nasopharyngeal. We have papilloma now, we will speak about it, but I'm speaking about the nasopharyngeal angiofibroma. It is the commonest benign non-epithelial tumor of the nasopharynx. It is the most common vascular mass in the nasopharynx. The most commonly accepted point of origin of juvenile nasopharyngeal angiofibroma is superior posterolateral nasal cavity. It is a benign, local invasive, adolescent predominant, and it is of unknown etiology. Debate exists whether this ever occurs in females. The tumor presents as nasal obstruction, recurrent epistaxis, smooth lobulated, red-gray mass originated in the posterolateral nares near the sphenopalatine foramen. Diagnosis is by CT or MRI, angiography or magnetic resonance angiography, MRA. R because it is a vascular tumor, so there is severe or contrast enhancement, intense contrast enhancement, are frequently used. Imaging demonstrates extremely dense contrast enhancement. Treatment is usually surgical with 6 to 24% recurrence. Preoperative embolization 48 to 72 hours preoperatively will reduce operative blood loss. If radiotherapy is necessary, gamma knife, which is called stereotactic radiosurgery, should be considered to spare adjacent structures, but this is rare. The surgery is the main treatment. Now we will go to another important subjects regarding the oral cavity and pharynx general. The tumors divided into benign tumors, which are very common, and malignant tumors. First, the benign tumors. Squamous papillomas are the most common benign tumors of the oral cavity and pharynx. Like their laryngeal counterparts, These papillary growths are locally non-invasive. Malignant degeneration of this benign tumor is rare. Polymerase chain reaction studies of the DNA of the oral papillomas failed to demonstrate any human papilloma virus type 6A or 11A, which is normally associated with the more aggressive types found in laryngeal papillomas of children. Really, if we see a papilloma in the larynx, it is very important, and we must do surgery sent for histopathology because it is a pre-malignant. While papilloma in the oral cavity and pharynx, usually it is a benign, even though any mass papilloma or any other mass must be sent for histopathology. You see, this is a very, see this picture, this is a very common papilloma in the oral cavity. Many patients are afraid, and also this is papilloma. This is from the uvula, and this is from the right tonsil. Now we go to the malignant tumors. The three important pre-malignant lesions of the oral cavity and pharynx are leukoplakia, lichen planus, and erythroplakia. Greater than 90% of malignant neoplasms within the oral cavity and pharynx are squamous cell carcinomas. Tumors of a variety of histologic types which arise from minor salivary glands distributed throughout the oral cavity, like adenocarcinoma or adenocystic carcinoma or others, are the second most common. Tobacco and alcohol use, advanced age, and male gender are the risk factors most commonly associated with the oral and pharyngeal squamous cell carcinoma. Excessive combined use of tobacco and ethanol results in a 15-fold increased risk to develop these cancers. While lymphomas are the most commonly encountered malignancy in pediatric age group. Now we go to nasopharyngeal carcinoma, NPC. The most common presenting sign or symptom of nasopharyngeal carcinoma is neck mass, about 60%, then oral fullness, 41%, then hearing loss, 37%. Other symptoms like epistaxis, headache, and cranial nerve involvement may be encountered. There is a relation between Epstein-Barr virus and nasopharyngeal carcinoma. Most nasopharyngeal carcinoma arise from fossa of Rosenmuller. Nasopharyngeal carcinoma commonly presents as otitis media with effusion. Now we go to the oropharyngeal carcinoma. The most common type of malignancy of oropharynx is squamous cell carcinoma, about 95%. The tonsil and tonsillar fossa are the most common location for carcinoma of the oropharynx. The most common presenting symptoms for oropharyngeal carcinoma are pain, dysphagia, and non-healing ulcer. Cervical metastases primarily occur in the upper deep cervical chain, with the jugulo-digastric nodes being the most frequently positive. Jugulo-digastric, or we call it upper jugular. Then we go to the hypopharyngeal carcinoma. It includes piriform sinus 70%, post-cricoid area 15%, and post-pharyngeal wall 15%. The most common site of carcinoma within the hypopharynx is the pyriform fossa. Now we go to the treatment of oral cavity and pharyngeal tumors. Really, there are many factors affecting the method of treatment of the tumors, like size, site, histopathology of the tumor, and other factors like age of the patient, or if the patient has other comorbidities to prevent surgery or chemotherapy or others. But generally, the following are types of treatment: surgery, radiation, chemotherapy, or combination, i.e. combination of surgery with radiation, we call it chemoradiation, or sometimes we use some tumors, it is resistant for radiation, so it is only surgery. This is the end of our fourth lecture. Really, because of the problems, بسبب الظروف الموجودة، أنا حاولت أنه أختصر. هنالك مواضيع أخرى أنا اختصرتها، كان بدي أعطيكم إياها لكن حتى ما نعقد الأمور عليكم. وأشكركم، وإذا عندكم أي سؤال أي استفسار، ما أريد أي واحد يتردد بأي طريقة كانت، حتى لو يحصل تليفوني من أي شخص، من أي طالب، من أي أستاذ عن طريق الواتس، أنا حاضر ومستعد. وإن شاء الله أنه نشوف نتفق على كويز نسوي لكم خلال هالأيام. شكرا.